Dear students, after studying this module, you shall be able to learn the concept of degenerative diseases, identify several degenerative disorders, learn the symptoms, diagnosis, causes and treatment of Huntington's disease, learn the symptoms, diagnosis, causes and treatment of Creutzfeldt-Jakob disease. Degenerative disorders are those that cause progressive degeneration of the brain cells, resulting in multiple problems which become more and more devastating with time. Such disorders are normally genetic in nature and effective cure has not been discovered for them. Such disorders affect many of the body's activities such as balance, movement, talking, breathing and heart function. Sometimes the cause is a medical condition such as alcoholism, a tumor or a stroke. Other causes may include toxins, chemicals and viruses. For some, the cause is not known. Degenerative nerve diseases can be serious or life-threatening. It depends on their type and severity. Treatments may help improve symptoms, relieve pain and increase mobility, but will not cure the disease. Several degenerative disorders have been described in medical and psychiatric literature such as Huntington's disease, Creutzfeldt-Jakob disease, multiple sclerosis, Alzheimer's, amyotrophic lateral sclerosis, Freire's ataxia, Huntington's disease, Lewy body disease, Parkinson's disease, spinal muscular atrophy. Huntington's disease and Creutzfeldt-Jakob disease have been the focus of much research lately. Huntington's disease, in 1872, George Huntington described this disorder as hereditary chorea. He described it as the tendency to insanity and sometimes that form of insanity that leads to sanity and sometimes that form of insanity that leads to suicide. Since then, search for the gene that makes it a hereditary disorder has been going on. Huntington's disease is a progressive subcortical dementia. It causes the progressive breakdown of nerve cells of the brain. It causes widespread deterioration in the cognitive, movement and functional abilities of an individual. It is invariably accompanied with the psychiatric disorders. Normally, the onset of disease occurs in the 30s or 40 years of age. If it occurs earlier than 20 years of age, it is known as the juvenile Huntington's chorea. The epidemiological studies indicate that it is quite a rare disease. However, there has been an increased interest in the search for the gene that causes the disorder. The symptoms are much more severe in that case. The epidemiological studies indicate that it is quite a rare disorder. However, there has been an increased interest in the search for the gene that may cause this disorder. Symptoms. The clinical presentation or symptoms show a wide spectrum of signs and symptoms. They are primarily of movement, cognitive and psychiatric nature. There are individual differences in terms of which symptoms will appear first and at what level of severity. The movement disorders may include dystonia, that is involuntary sustained contraction of muscles, chorea, that is involuntary jerking or writhing movements, rigidity of muscles, uncoordinated movements, abnormal eye movements, loss of balance and posture, abnormal gait, difficulty in swallowing and in producing speech. Some voluntary movements are also affected which cause functioning abnormalities. Another major kind of symptom is cognitive in nature. They include impaired executive functioning such as inability to make decisions, difficulty in planning and organizing things and thoughts, inability to initiate an actions which may be as simple as starting a conversation, lack of flexibility or perseveration, lack of impulse control, lack of spatial perception resulting in falls, difficulty concentrating on a task, slowness in processing information either while recalling old information or learning new materials, and lack of self-awareness. The psychiatric symptoms are also predominant in this disorder. They include a wide spectrum of abnormalities. Besides depression as the main clinical picture, the other symptoms include insomnia, distractibility, reduced appetite, reduced sexual interest, social withdrawal, feeling of worthlessness, and frequent thoughts of dying and suicide, constant fatigue and loss of energy. In some cases, fully developed disorder of obsessive compulsive disorder, anxiety, mania, and bipolar disorder have also been reported. The symptoms of juvenile Huntington's disease show greater severity. They include tremors, even seizures, changes in fine motor skills, rapid significant drop in overall school performance, loss of previously learned materials, rigid muscles, and numerous behavioral problems. In the light of the above mentioned symptoms, the common causes of death in the Huntington's disease patients include pneumonia or other infections, injuries related to fall, or severe difficulties in swallowing. Diagnosis. Diagnosis of Huntington's disease includes physical examination, a review of family medical history, neurological and psychiatric examination. The neurological examination includes the strength of reflexes, muscular strength and tones, sensation of touch, vision and hearing, coordination of eye movements, balance and general quality of walking. In psychiatric examination, the psychiatrist conducts tests to evaluate mood, mood swings, emotional states, presence of any hallucinations, decision making and other executive functions, disordered thought process, and evidence of any substance abuse. In order to study any brain abnormalities, brain imaging techniques such as MRI, PET scan are also carried out. A special feature of diagnosis is a genetic test, particularly in case of a positive medical history of the family in this context. Causation. Genetic analysis has been carried out to find out the etiology of Huntington's disease. It has generally been established that this disorder is caused by a genetic defect on chromosome pair number 4, one of the 23 pairs of chromosomes which contains the total genetic code for the organism. The defect causes a part of DNA called a CAG repeat to occur many more times than it should. Its normal repetition is 10 to 28 times. In this disease, it is found to repeat 36 to 120 times. The borderline range is considered to be between 35 to 40 repeats. The number of such repeats goes on increasing as the gene passes from one generation to the next. So the patient develops the symptoms at an earlier age. The gene on chromosome 4 is called IT15. It is passed on by one parent in an autosomal dominant inheritance pattern. So there is a 50% chance of the child acquiring the disease. It is a big gene with 3 lakh base pairs and is evident in all tissues of the body. The gene IT15 produces the amino acid glutamine. In normal function, how does it affect the disease process is not yet clear. The researchers have highlighted deterioration of caudate nucleus bilaterally in the neuropathology of Huntington's disease. The caudate nucleus comprises of striatum, globus pallidus and putamen. Striatum is a part of the basal ganglia which is control center for motor activity. The striatum controls the timing, ordering and sequencing of movement patterns. The striatum is connected to the limbic system and prefrontal areas via efferent as well as the efferent fibers. It has also been reported that in the most severe stages of disease, the prefrontal cortex may shrink by approximately 20%. The brain imaging studies have also indicated loss of cell mass in caudate nucleus and an enlargement of ventricles in patients of Huntington's disease. The PET scan reveals hyperfunction in striatum and the frontal areas of the brain. Treatment and prognosis. No treatment can cure or change the course of the disease since it is genetically determined. However, drugs can slow down the progression of the disease. Drugs to treat movement disorders like xenazine are administered to curb writhing and jerking movements. but their side effects increase depression, which is another major symptom of Huntington's disease. Antipsychotic drugs like Haldol and Clozaril may help reduction in aggression and agitation, but the side effects include an increase in dystonia and muscle rigidity. Antidepressant drugs like Prozac and mood stabilizing drugs like Klonopin have also been used. However, they significantly alter the state of consciousness and have the potency to cause dependence in the patients. Thus, there are no safe drugs for the disorder. Psychotherapy to some extent may control for the psychiatric manifestation of the disorder. It may not be highly beneficial since the origin of such psychiatric problems is genetic in nature. Creutzfeldt-Jakob disease. Creutzfeldt-Jakob disease, CJD, is also a rarely occurring subcortical dementia. According to estimates, only one person in 1 million in 1 year may be affected by it. It has a very fast progression. Within 3 to 4 months only, it can reach most severely levels. It occurs equally in all sociocultural groups. Normally, it manifests itself at the age of 50 to 60 years. Research on this has taken a spurt because of its similarity with the mad cow disease. In the early stages of disease, people may have failing memories, behavioral changes, lack of coordination, and visual disturbances. As the illness progresses, mental deterioration becomes pronounced and involuntary movements, blindness, weakness of extremities, and coma may occur. In sporadic CJD, the disease appears even though the person has no known risk factors for the disease. This is by far the most common type of CJD and accounts for at least 85% of cases. In hereditary CJD, the person has a family history of the disease and or test positive for a genetic mutation associated with CJD. About 5 to 10% of cases of CJD in the United States are hereditary. In acquired CJD, the disease is transmitted by exposure to brain or nervous system tissue, usually through certain medical procedures. There is no evidence that CJD is contagious through casual contact with a CJD patient. Since CJD was first described in 1920, fewer than 1% of cases have been acquired CJD. Symptoms. A complex of psychiatric and neurological symptoms appear in the disease. It was discovered by Creutzfeldt that his patient had symptoms both of mental illness as well as neurological. The patient felt that she was possessed by a devil and neglected her hygiene. On the other hand, she had symptoms of brain damage like unsteady gait, twitchy eyes, tremor, and a tendency to giggle inappropriately. Such symptoms indicated subcortical motor and emotional dysfunction. First described in the early 20th century independently by Creutzfeldt-Jakob, CJD is a neurodegenerative disease causing a rapid progressing dementia ending in death, usually within 8 months of the onset of symptoms. About 1 in 4 people with CJD begin their illness with weakness, changes in sleep patterns, weight loss, or loss of appetite or sexual drive. A person with CJD may first complain of visual disturbances, including double vision, blurry vision, or partial loss of vision. Some visual symptoms are secondary to cortical blindness related to death of nerve cells in the occipital lobe of the brain responsible for vision. Other symptoms include loss of memory, inability to make decisions, inability to abstract, problems related to language comprehension, disorientation, inability to attend and concentrate personality changes, and even hallucinations. Muscle spasm and jerking movements called myoclonus are also a prominent symptom of CJD. Balance and coordination disturbance, ataxia, is common in CJD and is more pronounced in its variants. Stiffness, difficulty in moving, and other features representing Parkinson's disease are seen and can progress to echinacea and mutism, which is a state of being unable to speak or move. Lack of coordination results in stumbling and falling. Muscle twitches, myoclonic jerks, and seizures may also occur. Diagnosis. CJD is diagnosed by a clinical neurological examination including electroencephalography, which shows characteristic spikes called triphasic sharp waves. Magnetic resonance imaging or computed tomography scan is done to exclude other forms of dementia. The CJD typically shows atrophy and or loss of brain tissue. Lumbar puncture or spinal tap may be done to rule out other causes of dementia. Cell count, chemical analysis and other routine tests are normal in CJD, and to identify elevated levels of marker proteins known as 14-3-3, blood tests may be carried out. CJD is conclusively diagnosed after death by brain autopsy. Scientists are investigating whether testing lymphatic tissues such as the tonsil may be an early tool in CJD diagnosis. Additionally, recent studies have suggested that other blood tests may be useful as well. Causation. Sporadic CJD makes up most cases. It occurs for no known reason. The average age at which it starts is 65. Familial CJD occurs when a person inherits the abnormal prion from a parent. One of the variants of CJD is Gerstmann-Straussler-Scheinzer syndrome, GSS, reported in only a handful of families. One of the most important manifestations of that is fatal insomnia. Variations on spongiform encephalitis have also been reported. The SEs have been found from Minkosto sheep to cows to humans. Kuru is an SE found in the 4 people of Papua New Guinea, which appears that where they ritually started eating their dead. The source of infection is not well known. The CJD attacks the cerebellum as well as the cerebrum. Astrogliosis is also observed under the microscope. It may be the result of increased glial cells to fill up gaps after death of the neurotonal tissue. Amyloid plaques are also found to be numerous, though they are also seen in other degenerative disorders such as the Alzheimer's disease. Electron microscopy has indicated small stick-like fibers in the cells of the brain as well as in the spleen, which are not found in other degenerative disorders. They seem to be the direct result of infection in the CJD. Classic CJD is not related to mad cow disease. It has long been known that humans can transmit this disease via implants of infected neural tissue, corneal transplants, or even by medical contaminated procedures. It may also be caused by eating contaminated meat containing neural tissue. That is how it got linked with the mad cow disease. After the infection, extensive sponge-like holes begin to appear on the brains of the victims. It gave the name spongiform encephalopathy to the disease. The CJD may be caused by an infectious agent, but it is not yet clear what type of agent that is. It is now understood that CJD is caused by a protein called prion, transmitted from victim to victim. The other spongiform encephalopathies are also hypothesized to be due to prion infection. All infectious diseases use nucleic acids DNA or ribonucleic acid RNA to code the instructions needed for reproduction. Inactivation of the nucleic acid destroys the capacity to reproduce. However, when these same measures are applied to infected tissue from spongiform encephalopathy victims, infectivity is not destroyed. Furthermore, purification of infected tissue to concentrate the infectious fraction yields protein, not nucleic acid. The prion hypothesis, as it is called, is now widely accepted, at least provisionally, by most researchers in the field. The most vocal proponent of the hypothesis, Stanley Prusiner, was awarded a Nobel Prize in 1997 for his work in the prion diseases. The prion is an altered form of a normal brain protein. The normal protein has a helical shape along part of its length. In the prion form, a sheath structure replaces the helix. It creates a new prion capable of transforming other normal forms. In this way, the disease process resembles crystallization more than typical viral infection, in which the virus commands the host's cellular machinery to reproduce more of the virus. Buildup of the sheet film causes accumulation of abnormal protein clumps and degeneration of the brain cells, which is thought to cause the disease. This crystal nucleation process is explained in terms of the fact that the infection provides a pattern that is the nucleus or catalyst for the reaction. Successive proteins that mutate by patterning themselves after the original mutant. Final answer to its causation are yet unavailable. The brain protein affected by the prion, called PRP, is a part of the membrane of the brain cells, but its exact function is unknown. Exposure to the infectious agents, of course, is still required for disease development. Prion diseases are not contagious in the usual sense, and transmission from an infected person to another person requires direct inoculation of infectious material. The basic question is to understand how a normal protein of the cells turns into abnormal. One of the hypotheses to explain it is that a small virus termed as viron may be present. A small bit of naked nuclei, acid infected with viron, diverge from the cells, attach themselves to proteins and force the mutation. Another explanation involves a non-biological form of replication. Familial CJD, on the other hand, does not require exposure to infections. It develops through the inheritance of other, more disruptive mutations in the gene for the normal PRP protein. The other two inherited human prion diseases, Gerstmann-Straussler, Schenker disease and the fatal familial insomnia, involve different mutations in the same gene. Most of the CJD cases are sporadic. They have no known routine or of infection or genetic link. Causes of sporadic CJD are likely to be diverse and may include spontaneous genetic mutation, spontaneous protein changes, or unrecognized exposure to infectious agents. Treatment and prognosis. There is no cure for CJD. There are no means by which the progression of the disease may be slowed down. Drug therapy and nursing care are aimed at minimizing psychiatric symptoms and increasing patient comfort. However, the rapid progression of CJD frustrates most attempts at treatment because decreasing cognitive function and more prominent behavioral symptoms develop quickly. Scientists are investigating whether some medicines that can break the abnormal protein form may be useful and whether a vaccine could help. Management procedures are more important than treatment. Providing safer environments, training family and other caretakers, family counseling, and even getting legal aid is an essential part of their management. Creutzfeldt-Jakob disease has proven invariably fatal. Death follows symptoms onset by an average of 8 months. About 5% of patients live longer than 2 years. Death from CJD has averaged approximately 12 months after onset. Prevention. There is no known way to prevent sporadic CJD, which is the most common type. Not everyone who inherits the gene mutation for familial CJD will develop the disease, but at present there is no known way to predict who will and who will not succumb. The incidence of heterogenic CJD has fallen with recognition of its sources, the development of better screening techniques for infected tissue, and the use of sterilization techniques for surgical instruments that inactivate prion protein. Summary: degenerative disorders are those that cause progressive degeneration of the brain cells. Huntington's disease and Creutzfeldt-Jakob disease have been the focus of much research lately. Huntington's disease is a progressive subcortical dementia. Its symptoms are primarily of movement, cognitive and psychiatric nature. It has generally been established that this disorder is caused by a genetic defect on chromosome 4. The defect causes a part of DNA called a CAG repeat to occur many more times than it should. Its normal repetition is 10 to 28 times. The researchers have highlighted deterioration of caudate nucleus bilaterally in the neuropathology. Creutzfeldt-Jakob disease is also a rarely occurring subcortical dementia. A complex of psychiatric and neurological symptoms appear in the disease. The CJD is caused by a protein called prion, transmitted from victim to victim. The other spongiform encephalopathies are also hypothesized to be due to prion infection. Creutzfeldt-Jakob disease has proven invariably fatal. Management procedures are more important than treatments. Thank you.